what are the benefits actually with the prone ventilation in the ARDS? The first one is the gas exchange, which means that there is better oxygenation or there is a decrease in PCO2. The second thing is that it is not the benefit of prone ventilation, not only it's a gas exchange, but also the most important part is the ventilator induced lung injury. The prone ventilation, it leads to the homogeneous ventilation in the ARDS patient. Put a patient on prone position, this it changes the heterogeneity to homogeneity, so it decreases the ventilator induced lung injury. Other benefits of prone ventilation is that may correct your acute cor-pulmonale, ARDS associated cor-pulmonale. So, if you put all together, there is improvement in gas exchange, decrease in the ventilator induced lung injury, the better hemodynamics, it improves the outcome in the patients with ARDS. Before going to discuss about the prone ventilation, first we should know about the sponge lung concept in the ARDS. So, we know all this all about the ARDS, like there is a ARDS is a non-cardiogenic pulmonary edema. It is a diffuse infiltrates or diffuse edema in the alveoli. If it is edema in the diffuse alveolar edema, it increases the lung weight. For example, the patient having this is a ARDS lung, this ARDS lung, there is a diffuse edema all over the alveoli. The edema of the alveoli increases the lung weight. So, that is the lung weight will be compared to this place lung weight will be very high. It going to be very high. Here it will be very high. So, the gravitational pressure, because of the increased lung weight, it increases, it squeezes out towards the air is squeezed out because of the increased lung weight. So, the edema increases the lung weight, it squeezes the gas out of the dependent lung regions. So, it producing the alveolar collapse. So, it is called compression atelectasis. It is because of that. Other thing is that our chest wall pressures, that is a chest wall and heart, it also compress your dependent part of the alveoli. The heart pressures usually more on the left lower lobe of the lung. This is the reason the most common cause of the most common lobe is collapsed in our ICU, it is a left lower lobe. One reason is the gravitational, second is our heart pressures, that heart and chest wall mediastinal pressure compress the left dependent part of the lung, most predominantly left lower lobe. So, that these two pressures will cause the dependent part of the lung will be more collapsed and the non-dependent part will be relatively better ventilation in the non-dependent part. The dependent part will be more collapsed with poor ventilation. What are the other changes you will see with the prone ventilation? If you see here in the patient with supine ventilation, there is a the two walls will be more compliant. So, for example, this is the posterior wall of the chest cavity, it is a spine and the vertebra will be there, this will be less compliant. The anterior wall of the chest wall will be more compliant, the diaphragm will be compliant, depends upon your abdominal pressure. Okay. Even the supine position, the pleural pressure will be, because of the anterior chest wall is more compliance, so the pleural pressure will be more negative compared to the dependent part. Okay. So, the abdominal pressure also, the gradient will be anterior compared to the anterior, the posterior the abdominal pressure used to be very high. If you see here, this is because of these reasons the dependent part of the alveoli will be collapsed. It will be more high in the patients with the ARDS, so that this will be normal, this part will be collapsed. When I put the patient on the prone position, what happened here? This is now that the anterior chest wall will be in the dependent part, my posterior chest wall will be non-dependent part. Okay. Even the posterior chest wall, this is now in the non-dependent position, but it will be because of the spine, the vertebra, it's a poorly compliant, okay, compared to the anterior chest wall. So, because of the prone position, the pressure will be, the anterior chest wall also will be more, it will be compared to the supine position, it will be less compliant. So, the pleural pressure will be here, you see here the pleural pressure is -6, here it is -10. Because of the posterior wall is already a poor compliant, because of the prone position, the anterior wall will be poor compliant, the pleural pressure will be homogeneous. So, it produces the homogeneous ventilation in the ARDS patient when you put the patient on the prone position. Okay. So, other thing is very important point is that differential ventilation in the supine position. In the supine position, I put a patient on positive pressure ventilation. Because of this pleural pressure is more negative in the non-dependent part compared to the dependent part. So, the most of the ventilation will go to the is a non-dependent part. This part will be received as a less ventilation compared to that compared to the non-dependent part. It is called differential ventilation. Okay. So, it is more common in the patients with ARDS.